Alright, so we're going to start with inflammatory bowel disorder. So the difference between IBD and IBS is that IBS is going to be a cluster of symptoms. There's no inflammation or change in those actual tissues with IBS, irritable bowel syndrome. Okay, usually it's a cluster of symptoms, it's not a disease. However, with inflammatory bowel disorder, it is just that bowel is inflamed. You're going to see changes in the tissues. A lot of times you're going to see blood with them. IBS, irritable bowel syndrome, you won't see change in the tissues, you won't see any blood. Alright, so IBD, it's a chronic disorder. It's characterized by exacerbations and remissions and encompasses many different disorders. Two of the main disorders are going to be Crohn's disease and ulcerative colitis. So those are the most common types of IBD. Crohn's disease is an inflammatory disease affecting primarily the distal ileum of the colon. The intestinal lining will ulcerate and it will scar and it will harden. So you'll actually see changes in the bowel. And you'll be able to see those whenever they do a colonoscopy on them. Fistulas, fissures, and abscesses can all occur. A fistula is an inflammatory channel between the bowel and the bladder or the vagina, or any of those other loops of the bowel skin surface. A fissure is going to be a tear in the actual tissue, and then an abscess is going to be a collection of pus with swelling and inflammation. With Crohn's disease, you're going to see a malabsorption of fluid and nutrients, and it frequently occurs that way. They aren't able to take in those nutrients, they're not able to absorb those things. And so a lot of times you're going to see anorexia with them. You're going to see malnourished people with Crohn's disease. A lot of times it's predominant in Caucasians, Jews, and smokers. Not really sure why, but that's what it is. The lesions are separated by normal tissue. So whenever we start comparing like Crohn's disease with the ulcerative colitis, that is one of the big differentiating symptoms between Crohn's and the ulcerative colitis is that the lesions, those ulcers, those fistulas, fissures, abscesses, whatever it is, ulcers in that colon, there's going to be normal tissue in between it. So you might have inflamed bowel here, but you'll have some normal tissue in between. With ulcerative colitis, you will not have that. So that's one thing that kind of separates the two. Crohn's disease is an autoimmune. It's exaggerated immune response, and that means that it's also going to be a chronic disease. Okay, so here's a picture of Crohn's disease. So you can have a hemorrhage, you can have perforation, which is a picture right here. You can have this cobblestone, which are ulcers that are spread throughout the normal tissue, okay? But in between, you see that this is normal, healthy tissue. You can have a fistula where it's a hole going through between those valves. You can see strictures where it is just kind of tightened off, okay? You'll also see obstructions of that bowel lumen. And with obstructions, we're going to have to do surgery immediately with this. When you hear inflammatory disease, think autoimmune and think systemic. Systemic means it's all throughout the body, okay? And so when we start talking about signs and symptoms, you're going to kind of see that. With Crohn's disease, it is a slow onset. You'll typically have very bad cramping, abdomen pain, tenderness, especially in the right lower quadrant, which is another kind of red flag that you want to watch out for. One of the signs and symptoms you want to pay attention to whenever you're comparing Crohn's disease with ulcerative colitis. Alright, pain with eating. If they take anything in to eat, it's very, very painful, and that often causes anorexia with this. Distension, possible fever, chronic diarrhea, and fatigue. And as it progresses, you are going to see anorexia, weight loss, dehydration, and nutritional deficiencies. So they're having a lot of chronic diarrhea. Whenever you're having chronic diarrhea, you're not able to absorb those nutrients from the food that you're taking in. It's just flushing through the body so quickly that it is going to be causing nutritional deficits, and you won't be able to get the nutrients in that you need. Anorexia, again, because they don't feel like eating. There will be periods of exacerbations and remissions. So sometimes they'll feel really good, and then other times they're going to feel terrible, and it goes back and forth with that. It is a chronic problem. Extraintestinal manifestations, problems occurring outside the intestine as a result of Crohn's, can include arthritis, anthragelia, basically really bad knots in the joints and things like that, skin lesions, inflammation of the eyes, conjunctivitis, disorders of the liver and the gallbladder, and usually they're going to resolve during the times of remission. So all of these problems that they have while they're in an exacerbation, like the arthritis and any kind of skin lesions, will clear up whenever they kind of get over that and go into remission. Diagnostics, we're going to be looking at their stool. Of course, we're going to see white blood cells in the stool samples. We'll also take a CBC. A lot of times they're going to have a low H&H due to blood loss, low protein and albumin, again, just due to malnutrition, not taking in the nutrients that the body needs, high white blood cell count, just meaning infection, high ESR, again, confirming that inflammatory disorder. CMP will show electrolyte imbalance. Barium enema is going to show a lot of inflammation. The colonoscopy is going to confirm, because it's going to show those lesions, those ulcerations, the wall thickening, the fistulas, and the inflammation all throughout the colon. And remember, it does have periods where it will be healthy, a healthy colon. It's very vulnerable to perforation during the scope because that tissue is just so tender. Biopsy during the scope is going to confirm diagnosis there. So for treatment, supportive therapy depending on the severity and the signs and symptoms. With Crohn's disease, surgery doesn't alter the progression or the recurrence of it, and usually it's only reserved for obstruction, perforation, or a fistula formation, like something that is really life-threatening to that patient. Otherwise, with surgery, it's not going to help them to go in and cut out the ulcers or cut out, the bad colon. Like we said, it goes through remissions, has recurrences, but going in and cutting out that bad tissue isn't going to fix Crohn's disease. So if there's an obstruction, perforation, or a fistula, that's when we might go in and do surgery. Diet changes according to the individual. Sometimes they're going to need supplements, vitamins, iron. They might even take some TPN. 5 aspirin medications, and you can see all your medications on page 751 through 753. So be sure to look through those and know those. But the aspirin medications, it's going to decrease that inflammatory response. Of course, we have to check for an aspirin allergy. If they do have an allergy, we wouldn't be giving this. Steroids, again, inflamed colon, so the corticosteroids, the prednisone, is going to help during the exacerbation period. And we'd only give the corticosteroids during an exacerbation. We'll modify enzyme activity. It's going to inhibit that inflammatory response, given when the 5 aspirin drugs don't control it. But of course, we don't want to overuse it. If we overuse our steroids, we know that that causes Cushing's syndrome, and we definitely don't want that. Antidiarrheals are used, but we want to use those sparingly and only when infection isn't present. So you think about that. If you have infection in the gut, you don't want to suppress that and stop the diarrhea. You want to go ahead and flush it out. So if there is infection present, we are not going to give antidiarrheals. You won't be giving Imodium. You want to get that infection out of the colon. A complication that can occur is going to be megacolon if we use that too much. So we want to avoid that as well. Immune modulators, if unable to maintain remission, that might be something that we have to look into. Analgesics for the pain, sedatives, antibiotics, all of those things will be used as well. Okay, so now we're going into ulcerative colitis. And again, there is a really great chart that kind of does a comparison in your book 749 or table 46-1. So kind of look between those two to keep them clear and kind of distinct in your head where you're not confusing them. Ulcerative colitis is going to be an inflammatory disorder of the large bowel and the rectum. Mucosa will ulcerate, it will bleed, it will become edematous, and it will also thicken. These lesions are continuous, okay? So remember, with Crohn's disease, we said there is some healthy bowel in between. Ulcerative colitis, there isn't. It's just continuous. Those lesions are continuous. Often we see this more in young middle-aged people, Caucasians, Jewish heritage. The colon will lose its elasticity and absorption is reduced. So again, you're having so many loose stools, you're not absorbing those nutrients the way that you need to. It's more likely to acquire if history of abscesses or perforations are there. And depending on how long you have ulcerative colitis, if you have it for more than 8 years, it will also increase your risk of getting colon cancer. So not a good prognosis there either. Signs and symptoms with ulcerative colitis, a lot of times it's going to be an abrupt onset, sudden severe bloody mucus and diarrhea. They may experience incontinence because they can't differentiate basically between a fart and actual stool. Abdomen pain, cramps in the lower left quadrant. Remember, with Crohn's disease, it was right lower quadrant. Ulcerative colitis, it's going to be left lower quadrant. Increasing pain with diarrhea, or eating increases diarrhea, weight loss, dehydration, fatigue. Diagnostics are going to be kind of similar to Crohn's disease as well. We're going to do some labs. We're going to do a barium colonoscopy and biopsy. And typical prep for those procedures will be modified just because they're not able to tolerate the normal prep. It's a little too aggressive, so we'll modify those a little bit. Clear liquid diet, gentle tap water enema the day of the procedure, and that's usually what we do instead of the heavy duty go lightly bowel prep for other colonoscopies. Treatment, first we're going to try diet. It's normal with increased calories and nutrition, so we're really going to up the calories on these diets, giving them high calorie, high protein. And then we're going to avoid any kind of foods that cause discomfort, blood products if there's severe blood loss, IV fluids and electrolytes if they're dehydrated, supplemental vitamins to replace all that which was lost. Surgery under non-emergency circumstances is going to offer the best possible outcome. With ulcerative colitis, that is one of our main treatments. Is going to be surgery, and you can actually read up on the surgery part of it on 755. It says surgery is necessary when the disease does not respond to medical treatment or with complications such as dysplastic tissue, a precancerous condition, perforation of the colon, or hemorrhage. And so basically with surgery, best if done under the non-emergent circumstances, you're going to get the best outcome. But they'll remove the colon, which means that they'll also need an ostomy. They may be able to create some anastomosis by removing problem areas and just reconnecting that bowel, connecting the intestines to the rectum and allowing the client to defecate normally. What you're going to see with this is often an iliac pouch, a J pouch, or even a couch pouch. And so it's basically a two-part surgery if it doesn't have to be emergency surgery. Of course, if they're having a bowel obstruction, you have to go in there and you have to do it quick. But like I said, it's best under non-emergent circumstances. They're going to have a better prognosis for it, and probably more than likely be able to have a normal functioning ostomy with that as well. Okay, we're going to stop right there.